A very good afternoon, and we are beginning our clinic now. So I extend my very warm welcome to the NITRD-CTD National Task Force Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our guest of honor, Dr. Soumya Swaminathan. Ma'am is currently the Principal Advisor to NTP at the Ministry of Health and Family Welfare. Ma'am truly needs no introduction. She has had an illustrious journey which began as Director of NIRT Chennai to DG ICMR, and then she took the role of Chief Scientist at WHO. She has played an important role in shaping the global health policies and initiatives. Ma'am's work has been recognized and been honored with several prestigious awards. Ma'am, a very warm welcome, and we are truly honored to have you in our clinic today. I also extend my warm welcome to our DDG, Dr. R.P. Joshi sir, Padam Shri, Dr. Behra sir, Dr. Additional DG, our presenter, Dr. Grinesh, Dr. Parul as case expert, state expert, Dr. Kiran, and other distinguished attendees. I can see some of the experts have joined us from Bangladesh also. So a very warm welcome. And I'm Dr. Neeta Singla. I'm Nodal Officer, DRTB Center at NITRD. To my right is Dr. Rupak Singla, who's consultant in the Department of TB and Respiratory Diseases. To my left is Dr. Saroj. She's a senior pulmonologist at NITRD. Now I request Dr. Manpreet Bhalla to deliver her introductory remarks. Dr. Manpreet ma'am, are you there? Dr. Manpreet ma'am, we can't hear you. I think there is some technical hitch. So by the time Dr. Manpreet joins us, if we have our DDG sir, Dr. R.P. Joshi.
Yeah, Dr. Neeta.
Doctor.
Yeah, sorry for the glitch. Good afternoon and welcome on everyone on behalf of today's NITRD to today's difficult to treat TB session Eco Clinic. And once again, I welcome Dr. Soumya Swaminathan. As Dr. Neeta has already introduced, she needs no introduction, and she's now the
private providers that we have to focus.
She's the principal advisor to NTP, now we will be taking her guidance in future. So I welcome Dr. Soumya. I also welcome Dr. Behra, who has joined, additional DDG, Dr. Mattu. And so I would just like to say that this NITRD, we started the Eco Clinics in 2016, way back. And this difficult to treat TB clinic was started in around 2 to 3 years back. We also have other eco clinics like HIV, thoracic surgery, pediatrics, and eco clinics for nurses, which is called as eNITI. The objective of these clinics was to increase the awareness and help the doctors in the periphery to be able to treat the cases which are difficult, like extrapulmonary TB, pediatric TB, CNS TB, and disseminate TB. And the target audience are the STOs, DTOs, the medical officers also, since the medical colleges are there. So all the faculty and staff of the doctors of the medical colleges also. So this was the objective of our today of the clinic. And so I welcome once again and over to Dr. Neeta to start the clinic. Thank you.
Thank you, Dr. Manpreet. Now I request our DDG sir, Dr. R.P. Joshi sir, to give his address. Sir, you are still muted, sir.
Good afternoon, all. Thank you, madam.
Thank you.
Good afternoon, all. Welcome from Central TB Division. On behalf of Central TB Division, I welcome all the faculty and all the participants for this very, very important academic exercise, which NITRD has been consistently doing at very high level of academic excellence since last few years. And a special welcome to Dr. Soumya Swaminathan Madam for gracing the occasion. And I congratulate the team for choosing a very, very important topic of adverse drug reaction. Because when we treat any tuberculosis patient, it is very important that we should anticipate and also look for adverse drug reaction, recognize them early, and we should also have a definite plan of action when anybody gets an adverse drug reaction. So this is very important topic, and I congratulate the team. And once again, I wish difficult to treat things all the very best. Thank you, madam. Over to you.
Yeah, thank you so much, sir. Your presence in our clinic always motivates us. Now, before I invite Dr. Soumya Madam for her talk, I would just request Dr. Singla to brief Madam a little about the clinic and what we have been doing in these clinics.
Very good afternoon to all. It's my privilege to welcome Dr. Soumya Swaminathan and all the senior faculty across the country. You see, we started our journey of managing tuberculosis and MDR-TB with this ECHO platform in 2016. That was the time when country was launching the new drugs like bedaquiline and later on the delamorate. So because we were using these drugs right from 2017 onwards, so we shared our experience with the rest of the country. And this really helped in the uptake and scale up of the newer drugs as well as the newer shorter treatment regimen across the country. Then in 2020, we formally joined hands with the Central TB Division and the National Task Force and named the clinic as NITRD-CTD-NTF Difficult to Treat TB Clinic. And since then, we have been carrying it on. And you see, in this clinic, we not only provide the treatment solutions to the cases which are posted there, but also our aim is to disseminate our national guidelines. And we try to cover all aspects of tuberculosis, drug-sensitive TB, drug-resistant TB, pediatric TB, extrapulmonary TB, management of various adverse drug reactions. And also we are covering the education to the nurses, and even surgery department is carrying on their clinic. So it's overall holistic approach which we are offering through these clinics. And ma'am, you will be glad to know today the entire country means all the states, all the union territories of the country are conducting their own difficult to treat TB clinic. There is a capacity building. They have their own experts. If they require our help, we are joining them. Otherwise, most of the time they are able to carry on their own clinics. And now we have decided for last 1 year, we are picking up one by one the states where the case has been discussed in their own clinic, and now they are presenting in the national level. So that's how these clinics are going on. And once again, ma'am, we welcome you to this clinic, and we hope that your suggestions and guidance will help us to take it further on. Thank you so much.
Thank you, Dr. Singla. Over to you, ma'am. We have also been hand-holding the other countries. We have, helped the African countries to start their own difficult to treat TB clinics, and we have started with Afghanistan also. So there are several countries we are hand-holding to start their own difficult to treat TB clinics. So now I request ma'am to give her insights for us.
Thank you very much, and Rupak. And good afternoon to everyone. I see lots of familiar faces, and so happy to be with you all today. I was actually there in ICMR when the ECHO program was started, and after the discussion with the ECHO team, especially with Dr. Sanjeev Arora, who's the founder of ECHO and happens to be alumni of the same medical college, I felt that it has a huge potential actually, especially in India and in countries like India, to where there are less experts and where the demand and the need is great, to be able to democratize the experience, the knowledge, which people like those working at NITRD and other tertiary hospitals, they have with doctors in the periphery who are actually struggling with clinical issues, with real challenges of managing patients, sometimes with limited resources. And by improving their capacity and capability, not just doctors, but the whole team really, can actually result in better health outcomes. So I'm so happy to see that 8 years later, that this initiative has actually blossomed and grown and is thriving. and that you have used it so well. And congratulations to the whole team at NITRD for leading this initiative and also for expanding it even beyond our borders. I think it's fantastic. And thanks to digital tools now we have and platforms, it's very possible to actually go across national borders. As we saw during COVID, there is nothing to stop us from sharing our knowledge, which really is free, and should be provided as far and wide as possible. So I think this is wonderful. Now, just a few words about where we are with TB in the country. And as you know, recently the ministry asked me to be an advisor, and I take it very seriously because I have spent a large part of my life working on the problems of TB and HIV, as of course more coming from a research point of view. But when I look back today and also look forward, I see that we are at the cusp of where we could actually make a dramatic change in the TB burden epidemiology today in India. And of course, if India makes a big change, then the world also moves. That's the power that we have because of the numbers. But we're also facing a situation which is serious, where maybe we should not have been in 2024, where we find ourselves in terms of TB prevalence, TB incidence, and most worryingly, TB mortality, TB deaths are way, way too high, given all the tools, the resources that have actually been applied, to solve this problem. And we've had program, WHO also had come out with the NTB strategy that basically has reducing deaths, zero mortality as a key goal, and then reducing the burden and the catastrophic cost due to TB. And on all three of these indicators, the needle has moved extremely slowly. Now, why is it relevant to the topic of the ECHO session that you all are running? Is that, okay, we're talking about difficult to treat TB. Now, difficult to treat TB is not only drug resistance. And I think we need to recognize that people who get TB often have many other issues. They may have medical issues like comorbidities, and they may also have social and economic issues. And without addressing all of those holistically, it may not be possible for us to improve the outcomes. So when I met with CTD about 10 days ago, essentially what I said is that if I only want to monitor one indicator, which is TB deaths, that is enough for me to know how the program is doing and how all of us collectively actually are making a difference or not making a difference in this case. Because with all of the efforts that have gone in, unfortunately, our TB mortality rates have hardly come down. They've just about come down very marginally. And so what we were talking about a decade ago of 1,000 deaths a day, we're still saying we have approximately 1,000 deaths a day. So this actually should be unacceptable, especially as doctors and as medical community. We should not accept this as something that we have to live with, but as a challenge for us to address and as a first priority to bring down TB deaths in the country rapidly, not a plan over 5 years or 10 years, but can we actually see a difference in the next 12 months? Now, we need to know why people are dying, obviously. And I think we have that data available. And particularly this group, it's a very large group. I see over 530 people on this call, and I'm sure your outreach is even larger. If we could come together as a community to urgently discuss, and all of you have experience of treating TB for many, many years. Some of you may be in tertiary hospitals, and some of you may be actually at the primary care level. But whatever it is, I think collectively we need to use our experience and analytic capacity to understand what are the major causes of death and what are the risk factors. And I think we know from our own experience the top 2 or 3 causes of mortality. And so we can begin to address those. So for me, I think that's the most urgent challenge. And when we talk about treating TB, I think we need to look at not just the drug regimen that is used, but what is going to be needed by that patient to keep him or her alive and in good health during and following the treatment of TB. So this means looking at that person as an individual and as a human being and situating them in the context of their own socioeconomic situation. Having worked with TB for a long time, I know that the social determinants are probably even more important than what we can give them in terms of drugs, because I've seen people dropping out of treatment, etc., just because the social circumstances make it so difficult for them to continue treatment. Now, if you take mortality and if you look at the cascade of care, then we can understand that unless everything is done right, we will not be able to reduce mortality. So it is not going to be one magic bullet that we can apply. It'll have to be, obviously early diagnosis, which means upfront molecular testing for everybody, upfront resistance testing for everyone, appropriate treatment, clinical management of things like undernutrition, of coexistent diabetes or HIV or any other comorbidity, maybe hypertension, maybe kidney problems, whatever else that patient has to be managed. And undernutrition is going to be a very, very important component of that with all the complications. And we've seen the results of the ration trial, etc. And then it's going to be obviously making sure the patient actually completes treatment, and then the follow-up. So I think that if we can analyze it from that point of view to say that where is it that we may be faltering right now or going slow and we need additional inputs. And, we've had several rounds of discussion with CTD in the last week where we have already said that, for example, like upscaling molecular testing, NATs, to cover every single presumptive TB patient is going to be like the #1 priority for us. Obviously, the availability of drugs is very important. And I think that has also had a setback in the last 2 years. And we've seen, after a long time, we saw drug shortages, which we have not seen actually in the TB program. So that was very unfortunate, but that is now being rectified. And hopefully we are not going to get into the situation of drug shortages again. We're also discussing the rollout of the BPAL-M regimen, because again, this was something that the expert advisory NTEG had recommended in 2022. All the preparations had been made, but for some reason it had been put on hold. But now we're trying to fast track the scale up of BPAL-M. And again, we're trying to simplify it, because when you have a public health program, it is important to keep things simple. The more we complicate, and right now, I think management of drug-resistant TB is very complex. But at least if we can say a universal MDR-TB regimen, which is a BPAL-M regimen, that can be the first starting point for anyone with rifampicin resistant. And we worry about the failures of that regimen. Hopefully, with experience of NIRT and other cohorts, you're going to get an 88 to 92% favorable outcome with a significant reduction in the death from 14% to about 2%. You will still have some people, obviously, who have the need for extensive second-line drug testing and, a sort of personalized regimen. But hopefully that number is going to be small. And therefore, the program can just focus on delivering this standard regimen to everybody who hopefully gets a rifampicin-resistant test done as soon as they arrive at the health facility and they've had their first diagnostic test done. So if we can do that, and if we can provide the BPAL-M regimen, then hopefully we bring a lot of needed improvement in the whole MDR, XDR treatment outcome space, reduce the need for these very complex cases to be managed to a smaller number. And then, of course, the experts would still need to interpret all the drug resistance results and, provide the right kind of put together the regimen. The other thing I am concerned is the fact that we always leave out pregnant women and children. And unless we have a good reason to do that, we should not exclude them. So I'm all for expanding access to treatment. And so, again, we need to be not just automatically and routinely put a term of, exclude X, Y, and Z, but really think about why are we excluding them? And is excluding them going to put them at more disadvantage than including them? For example, yes, we know that there are some unknown effects that certain drugs could have on the fetus, but we also know this woman has a much better chance of recovery if she gets these drugs. So it's a question of, should we be the ones deciding that, the woman should make this choice or that choice, or should she get a option to decide? Can she be given the information and be asked, you're pregnant, you're lactating, these drugs might cause this problem. On the other hand, your disease is very severe and you need treatment. And so rather than us deciding that the woman's life is more important or the baby's theoretical risk is more important, let her decide, let the family decide. Similarly, for children, I think that we have to be careful. I'm not saying that we should go and start doing things which are not in the guidelines. But what I'm saying is, let's be proactive. Let's not wait always for outside guidelines, for WHO or for any other agency to be telling us this, because that takes time. Whereas in India, we can, with the kind of resources we have and the kind of manpower and intellectual power we have, there is no reason for us not to work on some of these things like the pediatric treatment, as well as these other groups which are essentially always left out of clinical trials, and so we don't have data. I just want to mention that during COVID, the same thing happened. Pregnant women were not offered the vaccine because clinical trials had not included pregnant women. This is, standard. Now, what happened as a result was that WHO actually did change the guidelines fairly, as soon as we started getting some data. And there were a lot of groups worldwide who were campaigning for the inclusion of pregnant women. But in many countries, including India, pregnant women were not included in the campaign till quite late. And as a result, we saw deaths, unnecessary and avoidable deaths due to COVID. And later on, it was recognized that pregnant women were at a higher risk of dying of COVID because they were more likely to get severe pneumonia. So what I'm trying to say here is that there's a theoretical risk versus an immediate practical threat to life. And it's always very difficult to balance these two. And through the combined experience of this group that has been now discussing and managing patients for a very long period of time, collectively, I believe that we have the capacity and the power to move beyond guidelines and not to wait endlessly. So what I'm saying is, let's put people first. Let's put the patient first in front and see what does that individual need. Put ourselves in the shoes of that patient. When I used to work at NIRT, we often, as doctors, give lectures to patients, because we get irritated that patients are not following our advice. And it's very easy to blame the patient. Then I started going on field visits and home visits. We used to do that as a regular part of our work. And I saw the conditions in which these TB patients live, their families, the needs that they have. And then I said I should not be lecturing them, because if I were living like that, maybe I would also not be prioritizing my TB treatment, but rather I would be focusing on getting the next meal on the table for the family. So as health system sometimes becomes insensitive to the needs of patients, and also we are all bound by very rigorous protocols in many cases. So protocol is important. I think guidelines are important for a public health program. We cannot have individualized treatment. That is not what I'm suggesting. But what I am suggesting is that in addition to the TB diagnosis and management protocol, that we commit that we will not allow any TB patient to die. And, we were talking to some of the STOs and MD NHMs and talking about a death audit. I think it's a good idea because just like maternal death audits, India brought down maternal mortality significantly by making people accountable and responsible, so that if you have a maternal death happening in your area, the A&M and the PHC doctor and, everybody is actually held accountable. They have to explain what happened. An audit is held, the collector wants to know, everybody wants to know, etc. So I think a TB death audit in every district is a very good idea, but it should not just be, again, a theoretical exercise of a death audit. It should be combined with the interventions and actions needed to actually reduce TB death. So if we can have subsequent echo sessions on this, maybe Neeta and Rupak, you can think about how to structure this. But I think that, this is very critical, especially as we are approaching 2025 and we are not anywhere near the goals that were set by the Prime Minister, to get to the elimination goals. Fine. I mean, that was anyway a very ambitious target. So it's always good to have an ambitious target. So we have not reached that. That's okay. But what are we going to do next? What are we going to commit to? I think that goal is start with mortality. As we detect more cases, our burden will look like it's going up, but that's okay because we have first find all the cases. We know from prevalence survey, we have many more people in the community with active TB. We're not actually finding them now. They have minimal symptoms or they're not coming to the health system. So our curve will go up. We should not be punishing people for finding more cases, rather rewarding them. And then only it will begin to decline. But death doesn't have to go up like that. The death can actually start declining. So I think that I would like to stay and listen to the discussions that you have today. As I mentioned before, I strongly believe in the ECHO platform and the power it has to actually change practice on the ground. I think all of you who are connected are people who have voices in the field, your leaders, you're influencers, you can make a difference, you can spread the word. And if we can expand this using ECHO to cover every PHC, the PHC and the health and wellness centers, they don't have ownership of TB. This is a problem because unless it becomes part of comprehensive primary health care, we're not going to solve this problem. And so we have now wonderful new cadre of staff, the CHOs who are sitting at the health and wellness centers, and they are looking after 5,000 people. Out of 5,000, they will have how many TB patients? Maybe 2, 3, 4, not more than that. Can they not track and manage? We are expecting the STS to do everything, and now STS has to also go and do TPT, and STS has to go and do something else. TB patients I've spoken to and TB champions, they say, first treat us. Why are you asking our household contacts to come in? And I also heard that the screening is a problem, and TPT without screening for active TB is a huge issue. So we need to think about what is our priority. And if we can all focus on just that one priority, I assure you that everything else will fall into place. So that is actually my plea to you all, because I believe that, this group is a key group that's going to be able to make a difference. You have the NTF here, you have all the teachers, you have practicing clinicians, and as I said, these are the influencers and the opinion leaders in this group. So I think, Dr. Singla, you are in a very powerful spot. We can begin this change from today, and I would request you, and I'm there to support you in any way possible. Let us show a marked reduction in TB deaths in the next 12 months. So if we start counting from August 1 of 2024, and by August 1, 2025, can we bring down the daily death from whatever it is today? I think it's close to 1,000 a day, to half. We should go to zero. I think we have to go to zero. Going to zero, we may reach, down to whatever, 20 or 30%. That's okay. That's acceptable. But what is not acceptable is to say that let's just carry on doing what we're doing and hope that the results will be different. So Albert Einstein is the person who's often quoted as saying that if you go on doing what you're doing, then why do you expect different results at the end, right? So I think it's a time for an introspection and a time to each of us to put forward what we think might be a science and evidence-based, but also a humanistic and an ethical approach to TB management. Thank you very much. Back to you.
Thank you, ma'am. And it's so encouraging to hear you. Your presence itself is such a big motivating factor, and your words of wisdom, it's like you've answered so many challenges that have been going on in our mind and that we see in the field every day. So your insight into social determinants, family, patient, pediatric TB, pregnant patients, it's very encouraging, ma'am. Right now, I think more than 2,000 people are listening to you. We have 600 spokes, and at every spoke, there are at least 4 to 5 people. So more than 2,000 warriors you have today. So it's an army which is ready to do and whatever you advise and how you move. We all are there to support your vision, and we really want to work and achieve something for the TB program. Much, and it was really heartening to listen to you, ma'am. Thank you again.
Thank you.
So now we move on to our case presentation. Today's case is from the state of Gujarat. We have Dr. Grinesh Tamkowala, who's the assistant professor in Department of Respiratory Medicine at GMC Surat. The case expert is Dr. Parul Vadma. She's professor and HOD Respiratory Medicine at GMC Surat. The state expert is Dr. Kiran Rami. She's professor and head at GMERS Medical College, Surat. And national expert is Dr. Professor Digambar Behra. He's Professor Emeritus at PGI Chandigarh and Director Pulmonology at Fortis Mohali. There is also Padma Shri awardee. So a very warm welcome to the team. And over to Dr. Grinesh for his presentation.
Thank you, madam. So I am presenting a difficult to treat DRTB case. I myself, Dr. Grinesh Tamkowala. So I am presenting a case of 42-year-old female with a history of hypertension since last 10 months, and for which she is on telmisartan clothalidone combination.
आपका presentation हमको नहीं दिख रहा. Sorry to interrupt.
Excuse.
Yeah, just screen share कर लीजिए.
Yes, ma'am. एक मिनट, मैंने स्लाइड्स ओपन किया. Ma'am, is it visible now?
Yeah, it is visible. उसको सिर्फ आप हाँ मोड में स्लाइड शो मोड में कर दीजिए. नीचे से आप हाँ कर रहे हैं.
My slides is moving, ma'am?
No, they are not moving.
Okay, ma'am. Thank you very much, ma'am. I myself, Dr. Grinesh Tamkowala, with I am.
Grinesh मूव नहीं कर रहे हैं आपकी स्लाइड्स. प्लीज एक बार और चेक कर लीजिए, नहीं तो हम यहाँ से कर देंगे. Not an issue at all. Just move your. Are you moving your slides?
Yes, ma'am. I am moving my slides.
So they are not moving here. So maybe आप एक बार screen share बंद करके
Okay,
maybe
ma'am.
you should start.
Okay, ma'am. I will do that.
अभी बिल्कुल ठीक है डॉक्टर गिरीश. Please carry on.
Okay, ma'am. Okay, ma'am. Thank you very much, ma'am. So herewith I am presenting a difficult to treat DRTB case. I myself, Dr. Grinesh Thamakuwala, under the guidance of Dr. Parul Vadgama, Dr. Kiran Rhame sir, and Dr. Digambar Bera sir. And I am presenting a case of 42-year-old female patient having diagnosed with hypertension 10 months ago. She was managed with the antihypertensive medication telmisartan and chlorthalidone. Patient was obese with BMI of 40, for which she was managed with the diet modification and regular exercise. She has no history of tuberculosis. There is no history of tuberculosis in the family. As per the available investigations, the patient was in November 2023. She was having a USG hip, which is suggestive of multiple enlarged, partially necrotic conglomerated lymph nodes with a 21 into 25 millimeter at the supraclavicular region with FNSE of cervical lymph node, suggestive of the granulomatous tuberculous lymphadenitis. After these investigations, she was put on the 4-drug FDC, that is HRZE, under NTEP, since 25/11/2023. In December 2023, despite of a good adherence and adequate drug dosing, patient's condition was not improving. As per the patient, the size of a neck swelling was increased and showed the signs of inflammation. So the private practitioners had added tablet levofloxacin 1000 mg to the existing regimen. So patient took tablet isoniazid 450 mg, rifampicin 900 mg, tablet pyrazinamide 2400 mg, and tablet ethambutol 1650 mg, along with the tablet levofloxacin 1000 mg for next 1.5 months. Patient then from the private to a new civil hospital in January 2024. After 1.5 months of ongoing treatment, still patient ultrasound was suggestive of ill-defined abscess formation of the size 33 into 32 into 21 millimeter in the right cervical region level 4. We have advised for the extend biopsy, and extend biopsy of the cervical lymph node was done and sent for the histopathological examination, tissue gene expert, and biopsy TB culture. Patient's tissue gene expert was suggestive of the MTB very low detected with rifampicin resistant detected. Tissue for the on the 27th January, the tissue for the TB culture and DST was sent to the IRL Ahmedabad, which has ultimately no MTB has grown in the culture after 2 months. This is the tissue gene expert report suggestive of rifampicin resistance. So we have evaluated this patient to start a DRTB regimen, and pre-treatment evaluation was done, which consists of a blood workup, ophthalmology, and psychiatric evaluation. At that time, patient's CBC was normal, with hemoglobin was 12.4 gram per deciliter. Patient's RFT, LFT, including electrolytes, were normal. amylase lipase was normal during the pre-treatment evaluation. At that time, patient's ECG was also within normal limit, with QTCF of 438 millisecond. So patient was put on the tablet bedaquiline 400, levofloxacin 1000 mg, linezolid 600 mg, cycloserine 1000 mg, clofazimine 200 mg, and pyridoxine as a part of bedaquiline all oral longer regimen since 2nd February 2024. Since then, the patient is on regular follow-up with us in a new civil hospital, Surat. After 1 month, patient was admitted with us with the complaint of the weakness, giddiness. Patient has bilateral lower limb tingling and numbness, and the generalized muscle cramps for the past 20 to 25 days. And the patients, as per the patient history, these symptoms are progressive. So we immediately hospitalized her. On admission, her ECG, we scored that ECG having a QT prolongation of the 570 millisecond with multiple VPCs. Her complete blood count was suggestive of hemoglobin was 7.2 gram, which was initially 12.4 gram. So there is a significant drop in a hemoglobin. Then patient's electrolyte having a significant hypokalemia with serum potassium of 2.8, having severe having hyponatremia with sodium is 128, hypomagnesemia with serum magnesium 1.5, and hypocalcemia with serum calcium of 7.8 milligram per deciliter were noted. So as the patient is having a significant giddiness, so we have done MRI brain also, which was normal. Patient's chest X-ray was normal. This is the ECG at the time of admission, showing a multiple VPCs with a prolonged QT interval. So, as a part of management, we have initially hold the whole regimen, all the drugs we have put on hold, and we have, as the patient is having electrolyte disturbances, we have replaced the electrolytes, including potassium, sodium, calcium, and magnesium, as per the protocol. We have done the monitoring, ECG monitoring twice daily as per our PMDT guidelines. And then hematologist, cardiologist, and then neurophysician opinion was taken. So hematologist has advised to hold the tablet linezolid. Mostly to his patient has been diagnosed with the linezolid-induced anemia, and patient has transfused with 1 unit of the PEG cell volume. The neurophysician advice has also taken. He is also suspecting linezolid-induced peripheral neuropathy, and he has added tablet pregabalin to this patient. The cardiologist advice also sought for the QT prolongation. He has advised to correct the electrolytes, and he has replaced the telmisartan chlorthalidone with the telmisartan metoprolol. So patient's chlorthalidone based combination has stopped and switched the antihypertensive to metoprolol based regimen. After 10 days of the admission, patient's hemoglobin was 10.8 gram percentage. Serum potassium was 4.2 milliequivalent. Serum sodium was 143. Serum calcium was 9.4. Serum magnesium was 2.0, and ECG was within normal limit. All the electrolytes are within normal limit. So as the patient QTCF was within normal limit, it is less than 480. We have sequentially added tablet bedaquiline, tablet levofloxacin, tablet clofazimine, and tablet delamanid, which we are giving in place of linezolid, as we have to hold the linezolid in a view of significant severe anemia and peripheral neuropathy. So we have added this drug in day by day with daily ECG monitoring, and the drug was newer drug was added every third day with the fact that all the ECGs has showing the normal QTC. So ECG monitor. Then after also ECG monitoring was done daily, and patient was discharged. At the time of discharge, the patient's ECG was raised with the QTC of 423 only, and patient was advised for the regular follow-up. But on the follow-up, despite having all these treatment, patient's bilateral lower limb tingling is not improving. So we have again taken neurophysician advice, and we also know that cycloserine may be the cause of this. So we have hold the cycloserine of this patient, and replace it with the pyrazinamide. And patients, the symptomatic treatment for peripheral neuropathy has stepped up with pregabalin, duloxetine, and oxcarbazepine, carbazepine. So after this, the patient has advice for follow-up weekly for the 1 month. Now, what is the present status? At present, she is in a regular follow-up with us. She is not having any other complaints apart from the numbness of feet. So, from this case, my point of discussion is first point is the drug-drug interaction, particularly bedaquiline and all these QT prolonging drugs, along with the antihypertensive, particularly a diuretic group of antihypertensive. Another point is the adverse effect, which we are seeing that the linezolid induced the myeloid suppression and peripheral neuropathy, cycloserine induced peripheral neuropathy, bedaquiline, levofloxacin, and clofazimine induced raised or the prolonged QTC, and introduction of the delamanid as a replacement drug, despite the fact that it has also a potential of having a prolonged QTC. But as we have done it with the regular ECG monitoring, we are managed to do it. Thank you, madam.
Thank you, Dr. Dinesh. Are there any questions to Dr. Dinesh regarding the investigations, diagnosis, or treatment before I take the expert?
Question is there.
Do you have any questions on the chat?
Yes, ma'am, we have few questions on the basis of history. Yes, we have few questions on the basis of history. Like with the history, we can make it out to gene expert. Patient was not, when he was taking from the private, there was no gene expert was not done. Universal DST was not done in that patient. Yes, Girish?
Hello.
It was started on the basis of ultrasound and clinical presentation.
And FNSA report, madam.
In FNSA.
FNSA suggestive of granulomatous lymphadenitis.
Yeah.
So they have started the patient on the first line anti-TB treatment based on the clinical scenario and this FNSA report, and they have added levofloxacin also. And levofloxacin, when we have seen the patients, he was already on this 4-drug regimen with levofloxacin for more than 1 month. And at that time, patient is not diabetic. Her SbA1c is 4.5.
Thank you. And was nerve conduction test was done when the patient come up with symptoms of
Yes, ma'am. NCS has done. So we have, as we have already described in the case, we have already done a neurophysician opinion for that, and he has done the NCV, and based on this, he has diagnosed that this patient is having a drug-induced peripheral neuropathy. Apart from he has ruled out all the other causes of these symptoms of her peripheral neuropathy, and based on that, we have stopped the linezolid, and also the patient is having a severe anemia, so we have to hold it.
I'm Ravindra Diwan. I have got 2 questions. Number 1, was the X-ray chest, because X-ray chest has not been shown. Is there no pulmonary or mediastinal lymph node tuberculosis in this?
Sir. Hello.
Hello. Was X-ray chest done? No lymph node.
Chest was done. X-ray chest was NID. There are no any mediastinal lymphadenopathy or no parenchymal involvement or no pleural involvement.
Okay. Another question was, when the lymph node biopsy was done, was a total excision of lymph nodes done or only specimen?
Yes, excision biopsy has done. We have done the total excision of the lymph node. In it, gene expert has been done, and the liquid culture also done, but liquid culture में सर फिर MTB grow नहीं हुआ.
Okay, thank you.
And gene expert is having this rifampicin resistance.
One question, Dr. like this patient was having TB lymph node, this was resistant to rifampicin, and we do not have the resistance pattern of the other drugs. Why didn't we consider for starting the patient on shorter regimen instead of switching to the
Madam, because patient has already taken levofloxacin for more than 1 month, so we have plan to give this a longer regimen only, because as per the PMDP guidelines, if this patient is already having fluoroquinolones, which is more than 1 month, so we have put this patient directly on the longer regimen rather than shorter regimen.
Thank you. Thank you. We have Dr. Parul with us, who's the case expert. Ma'am, would you like to add something to this?
Yes, good afternoon, everyone, and good afternoon, all seniors and panelists. Sir, as we have already listened to the case, and we have discussed many points to be discussed, but here I would like to specifically discuss about the anti-hypertensive drugs like chlorthalidone, which was given as an anti-hypertensive. We have to be careful while when the patient is on anti-hypertensive drugs, which can cause electrolyte imbalance. So here the message from my side, or the point of discussion, is that it was replaced by metoprolol, which is a better antihypertensive and which will not cause any electrolyte imbalance, and specifically not lead to QTc prolongation. So one point of discussion is that when patient has multiple illness, we have to be careful that drug-drug interactions and the electrolyte imbalance can be caused by any other antihypertensive or any other drugs, which is one of the comorbidity in the disease. Second point which I wanted to discuss is that whenever we consider for sequential adding, as we have discussed that according to guidelines, delenamide is a drug which has to be added. But yes, if we stop one more drug, we can add amikacin according to guidelines. And third, the drug which we can add is pyrazinamide. But in this, we cannot. We didn't want to give the injectable regimen, so we added pyrazinamide in this patient. One more thing which I wanted to discuss is that most of the times we find that linezolid induced neuropathy is there, and we supplement the patient, we do the NCV of the patient. But in this case, what we found that after couple of 20 days, 30 days also, patient was not improving. So most of the times we think that linezolid causes irreversible neuropathy, and we think that theek ho jayega, it will be improved. But yes, along with suspecting the linezolid induced neuropathy, we have to suspect that cycloserine also can cause neuropathy, because most of the times, 99% of the cases, we suspect linezolid can cause this. And of course, we have to take care and follow up the patient for the anemia, which can be caused by linezolid in many of the cases. So this is my submission regarding the ADR, regarding the cross reactions, and of course the electrolyte imbalance. But yes, we here we also suggest that whenever patients are taking treatment from the private sector, coming to us with 1.5 months, 2 months of levofloxacin, which is added to a failing regimen or maybe not improving regimen, then we are bound to shift that patients on oral longer from the first step. And in this case specifically, when we got the CBNAT report, it was rifampicin resistance and history of more than 1.5 months. So we had to start patient on oral longer regimen. But multiple ADRs can happen in one patient. We have the MDR ward with a ICU also set up. We have ventilators for XDR patients, MDR patients. We have critical, cardiac setup for critical monitoring of the patient, and with the facility of hematologist, neurophysician in the same roof, we could manage this. So this is my submission, madam. Thank you.
Yeah, thank you, Dr. Parul. We also have our state expert, Dr. Kiran sir. Dr. Kiran sir, would you like to add something?
Yes, it's a very good case, a classical case of TB lymphadenitis, right side cervical lymphadenitis. Patient treated at government AKT, HREZ plus early adding of levofloxacin. So it's not required to early adding of levofloxacin. So the other patient go into short oral instead of patient going into oral longer regime. So early detection of this and early biopsy report suggests of resistance. There is no other resistance is found, but the patient subsequently developed some ADR in the form of linezolid peripheral neuropathy, thrombocytopenia, and the cycloserine induced also. So it's a very good case and very well managed by our team. Thank you.
Thank you so much, sir. We are also, before I invite Dr. Behra, sir, there are a few questions that we'll take from the chat.
Yeah, so this is one question in particular, which is well explained by Dr. Parul already. That the patient was, when FNAC was done in Gene Expert, it was showing MTV detected low and resistant. Should we take it seriously or not? But ma'am has already explained, patient was taking first line ATT, and now the culture has not grown and patient has not shown any improvement for the past 1.5 months of taking first line ATT. So, ma'am, what's your say on this? Shall we should have considered for giving first line ATT, or should have repeated the sample to confirm drug resistance in this case?
Ma'am, see, extrapulmonary TB is, we all know it's a possible ancillary condition. When one gene expert is showing that it is rifampicin resistance and it is detected, whether it is low, high, or very low, but that time we can, many a times we don't get sample again and again. So one sample gene expert showing rifampicin resistance, we have to consider the resistance, and specifically when patient has taken more than 1.5 months of AKT, second line AKT from private. In such cases, we have to be serious that patient has to be given oral longer regimen. So this was a clear case of rifampicin resistance, documented resistance. It is not on just FNAC report. And in fact, we are seeing clinically also many cases. So specifically when patient is having long-term or recurrent illness, we suggest biopsy also, and we suggest gene expert for biopsy also, and histopathology, and of course culture if the patient is coming for the second time. But yes, in this case, it is rifampicin resistance, which is very well documented. So we have to start the drug resistant regimen. And clinically, improvement was not there. Though we, in routine cases, if there is no resistance, we wait for MAP 2 to 3 months. It can be, some exaggerated reaction also. But specifically, when resistance is documented, we should not wait.
Right, ma'am.
Thank you, Dr. Parul. Dr. Rishi has raised his hand. Dr. Rishi? So you're muted.
Ma'am.
Yeah.
Ma'am, my concern is that since just we want to know the grading of the NCV, what was the grading, and in spite of being giving the stopping the linezolid plus giving the pregabalin, dextromethorphan, oxycarbazine, patient is still having the numbness of feet. Though cycloserine was also being given. So one message is that we have to look this numbness of feet as a precautionary measure priority, that we should, as soon as the patient should complain of some numbness of feet, we should stop all these things and go for the alternative medicines as for this one. And my concern is what is the grading of this, and why this patient, after so much of substitute medicine we are giving, patient is still having numbness of feet, madam, bilateral.
Hello. Sir, the patient's NCV grading was, she's having a severe peripheral neuropathy. And as we already know that linezolid is prone to have adverse drug reaction like irreversible peripheral neuropathy. So that may be possible. Many a times we have seen the patient that the symptom may persist for 6 months, and in many of the patient even after completion of the treatment. So that is why it is very important, if the patient, any of the patient coming with a symptom of the burning of feet or tingling, initially we have to evaluate for all the other possible comorbidities like diabetes, B12 or thyroid. We have done all that thing, and that is why we have all that report was normal, and so we have taken the opinion from the neurophysician, and he has also NCS has also done, and with the diagnosis that all the other reports are normal, and still patient is having peripheral neuropathy, then this is the only a linezolid induced peripheral neuropathy. So my point is that whenever this kind of patient with symptom of burning of feet, we have to take it seriously, because the linezolid is prone to cause this irreversible peripheral neuropathy. We still don't know, as the patient is on treatment, and we still don't know that whether in this patient it will be reversible or not. But up till now, patient is patient is well, but patient is not 100% free of this peripheral neuropathy. Patient has improved, okay, from the treatment the patient was put on. Patient was improved from there, but still she is having a symptom of this numbness.
So just
So, sir, my concern is that, yeah, my concern is that it means that we have to say that patient that though these symptoms have come, but it will persist after the treatment is completed also. So we have to also counsel the patient regarding this, because patient will say, "Oh, मेरा ये काम तो हो गया, but now ये पैरा में दिक्कत आ गई है." So we have to counsel at the initial stage that these symptoms may persist till the end of the treatment also, or
Yes,
maybe
sir.
later also, sir.
So we practically we have so many patients who were diagnosed as linezolid induced neuropathy. We stopped, we decrease, as such we decrease the dose after IP, but we decrease the dose or we stop the treatment in many patients, but still there is a part of neuropathy even if they are at the end of the treatment. So it is definitely irreversible, but in this case it was severe, sir, and after stopping the drug also the patient was not improving at all. So looking to the patient after 15 days, neurophysician told that it can be because of the added side effect of cycloserine also. So they advised us to specifically stop cycloserine in this case also. Otherwise, in every patient, we don't just stop cycloserine also. We just stop linezolid or decrease the dose of linezolid.
Okay.
But in this case, there was no improvement at all after 15 days also. And so in this case specifically, because it was a severe case, so it was an additional advice from the neurophysician to stop cycloserine also. But in other mild cases or moderate cases where there is less neuropathy or less tingling, we can definitely think first of stopping the linezolid, wait for 15-20 days to get improvement or maybe 1 month. And if it is not severe, we can wait for 1 month also to stop cycloserine. So this is because of the severity of the case, this decision was taken, and non-improvement after 15 days.
And also the patient is having severe anemia.
Thank you, ma'am.
So we have to hold linezolid in this patient.
Okay, thank you, Dr. Grinesh. We have Dr. Behra with us. Sir, can we have your comments on the case?
हमारा मोबाइल में करते हैं वो हमारे बंद कर दिए रास्ता में सामने
Yes, thank you.
Yes, sir.
I think there is a question. Somebody has raised the hand.
Yes, we have Dr. Lokender who has raised the hand. Dr. Lokender, your question.
Good afternoon, everyone. Ma'am, I have gone through the case, but I think I have missed whether they have mentioned the HIV status of the patient or not. That I want to
Negative. Sir, HIV was a negative in this case. I think we have missed that put in this slide. But it is negative.
Negative.
Yes, sir.
Thank you, thank you. And STDC West Bengal has raised hand. Question from STDC.
Good afternoon, respected ma'am and sir. It is a very good case of extrapulmonary TB. My question, I have also the answer. My question is that very low MTB detected, rifampicin resistance detected. So, do you have any idea how do you confirm that this rifampicin resistance is false or true? By seeing that particular result, I am directly going to the question. Okay, you have got the report, MTB detected very low, rifampicin resistance detected. So by seeing that report, can you confirm that this rifampicin resistance is false?
So specifically, when there is a report which is showing that it is clearly bacteria is the gene is detected and there is rifampicin resistance which is there present and low, then in that case we have to take it up. If it is showing as indeterminate according to guidelines, indeterminate, then we have to repeat the sample and repeat the biopsy and take the sample again. But in case when there is clear cut showing that rifampicin resistance is there and the clinical opinion is there, clinical presentation is there, in that case there is no doubt in this case to suspect that there may not be resistance.
Actually, by the system, if you see the report, you can confirm that this resistance is true or false. Okay, I'm just citing the protocol.
Sir, I got your question. We'll take this question with one of the microbiologists that we have.
Can I come, madam?
We have Dr. Ritu from NITRD. She's a senior microbiologist. Dr. Ritu, are you there?
Unmute person. Third row left.
Dr. Ritu, you're muted.
Ma'am, please
Hi, ma'am.
Yeah.
Actually, I didn't get the question. I was also.
Sir is asking that looking at the report which says that MTB detected very low, how do we confirm that there is a resistance pattern?
No, we can confirm the resistance pattern if the report is telling so. If the report is telling that is rifampicin resistance, we can take it up like that. It's not saying indeterminate, right?
Please kindly let me explain then. I am myself is a microbiologist. I am now just going to explain. Okay. Now, when there is this report, you just go and see there are 5 probes A, B, C, D, E. Now we have to see in case of rifampicin resistance that which probe gives the CT value 0. If the CT value is not 0, and obviously the highest and lowest probe CT value, if it more than 4, then this platform will give you rifampicin resistance. So if one of any probe value CT is not 0, then it is a false resistance. So it is better always we have to learn not to read the only report, but the CT value, particularly in case of rifampicin resistance. Suppose I am giving one example. Suppose the highest CT value of any probe, say A, B, C, D, E, the CT value is 20 and the lowest CT value is 12. Then the CT value is more than 4, but it is false resistance. So,
sir, I will like to just interrupt you for a minute. Sir, I understand about the CT value concept also. Having said that, the expert in the case of very low, if it is not able to determine, it itself tells about the indeterminate, which is going to be read as such. But if it is says resistance, then either ways we have to just, see it with the pinch of salt, whether it's whether that sample has to be repeated or not in the case of pulmonary, because no clinician is going to sit back and see those probes very easily.
No, ma'am. It is very easy to see the analytics, ma'am, and then sorry to interview, ma'am. That it is not the platform is made in
Okay,
such a
so
way.
your point is well taken. We fully understand that if there
Just
is
let me complete me, ma'am. One point, ma'am.
Yes, sir.
That the thing is that the platform is made in such a way. Every PCR system is made in such a way that the highest and lowest probe value, if it is more than 4, but in that case we have to see whether any of the probe mutation value CT is 0 or not. And it is very easy to see in that CBNet platform. If you go to just make a one click and you see that 5 probe, if any of the probe value mutation is there, then the CT value must be 0. And if any of the probe value CT value is not 0, then it is a false resistance. And it basically happens in case of possibility, particularly in this case.
Thank you, sir. So your point is taken. Thanks for the information. It's new information for us. Dr. Narendran has raised his hand. Dr. Narendran.
Ma'am, I would like to add on to what he has said. This kind of an ethical dilemma always occurs. So it's very difficult, as you are rightly as the adjudicator, it's difficult to err on this side or that side. But we have seen this kind of a phenomenon, hundreds of patients when gene expert was a rarity previously. So by the time the patient would have become all right, but finally the result comes that the gene expert is positive and it is resistant to rifampicin. So I agree with the former speaker that you can have false resistance, especially with lymph nodes, because it's after all a mutation which is picked up sensitively by the gene expert. So it's always good to repeat it, or it's always good if but I agree with this representer on the other hand that it's not very easy to get extrapulmonary specimens. So it's a 50-50 right from both sides. It's very difficult for us to judge, but it requires research on this.
Sir,
Right.
sorry, I'll
See, in this context, one more thing is, if you see in the practice, how many times you have the gene expert report with you? Most of the time, especially from the private sector, patient comes to us with a report from the laboratory on the laboratory letterhead. They don't give you the actual report. So, and many times we have seen transcription errors. One of my patients was sent to me with a laboratory report mentioning reef resistance intermediate. Then I said, well, there's nothing called intermediate. So I insisted to get the actual report. And when the actual report came, it was showing indeterminate. So please insist that we want to see the printout of the machine. And then we can look at these things, whatever has been discussed, to see whether it's a false positive or not. Plus, the number two, we always need to see the clinical background scenario. When MTB detected very low and there is a reef resistance, something like this, please go back and also see if the clinical probability is high. In that case, we can go ahead with this report. In case you find clinical probability is very low, patient has never taken treatment, there is no history of contact and all this. In that case, one may repeat the test to really be sure what we are treating. That's my point of view.
Sir, I just like to add on. I totally agree with Dr. Singla, sir. He summarized it so well, and that is what it is. Indeterminate is indeterminate. We know we can get false resistance in very low. Everybody knows it. That is why it's suggested to repeat. But if you're not able to repeat for operational reasons or because it's an extra pulmonary, that is a scenario in which you can just go back to the clinical picture, because even the probes thing, even the CT value itself is usually that point is not available with the clinician, it's available with the microbiologist. And sometimes even a one error or two error of CT value alone is not enough to justify even calling it that. That's all.
Thank you, Dr. Ritu. And there is Dr. Paresh who has raised a question. So, ma'am, you can answer both the questions together. Dr. Paresh?
Yes, ma'am.
Yeah.
Ma'am, actually, what sir has told, the microbiologist was told, it is very correct, because I am working for last 12 years in this medical college here, SUV medical college here in the lab. So my experience speaks of that probes analysis, actually the microbiology has to done it prior to providing the results. So if any pulmonologist or respiratory specialist asks about it, that whether it is a resistant or resistant, so that is the answer they can summarize, but not needlessly it's required that the pulmonologist or a respiratory physician should ask about, and they should come and see these results, because they should have a confidence on the microbiologist who is doing, the qualified microbiologist who is giving this about this, because the probes which are there, so it is very clearly what sir has told, it is very clear. So if there is a mutation, so absolutely you don't find is a 0, 0. The CT value and the cycles which are there in that graph, you can compare. And the next thing is that if the delta CT value, which is more than 4, what sir has told, the highest and lowest, that also sometimes you see the probes, but the CT end value endpoint will be like that. So from that comparisons also, though 5 probes are visible, but they are still, it will show the resistance. So machine has no role. Machine is very clear about the interpretations. But thing is that clinical findings which are there, so after giving half month of a treatment, it is not responding. So that is the query. So we should accept the result. That is my question. That was my number one clarification. Second thing is that I put a question also. LPA has been done or not done? First line and second line. In this case, I didn't find the results of LPA. So that was my query. So whether it is a quinolone resistance or is a quinolone sensitive. So when we have started a bedaquiline containing regimens, and we should know the quinolone, what about the quinolone? So that thing also is not being presented. So that this is my query, madam. That much I can speak.
Yeah, thank you. Thank you. Dr. Parul, would you like to answer that?
Ma'am, just first to see, when we are sitting in the OPD, practically the problem is that when the patient comes with this type of report, which is having rifampicin resistance and patient not improving in this era of medical legal aspects and sort of CPA, ma'am, it is very difficult to say when the patient is having report that rifampicin resistance is there and you tell the patient ki nahi theek ho jayega, yahi dawai chalu rakho, practically without evidence we cannot even take the decision not to give the higher regimen. So that is my first submission, because patient nowadays not only in private setup, in government setup also patient do case and they have their own way of fighting, which is also correct on their behalf. So if there is evidence of resistance, we have to, as a clinician, we have to think further for taking the treatment upgraded. Second point, yes, sir, we have not submitted this patient for LPA. This was for given for liquid culture and sensitivity. So in that we have not found any growth. Yes, rather if the patient would have for the first time came to us and then we would have done excision biopsy, definitely we would have sent it for LPA also. But in this, the sample was very less, so it was sent for only liquid culture. But it should be sent. It should be sent.
Yeah, thank you.
I'd like to also say that in any case, it's an extra pulmonary sample. So either ways, you would have had to do first culture only, then you would have taken up for LPA. So either ways, it wouldn't have been sent.
Yes.
Thank you. Now we have Dr. Behra with us, sir. Over to you for your comments, sir.
So thank you, Dr. Nita, and a very good afternoon to everybody. I think a very nice, inspiring talk by Dr. Soumya, and I think things will improve now. As she being taking over as the chief advisor, I think things will be changing, I hope, in the program. And she has highlighted many things. And coming back to this particular question, very nice and interesting discussion. I'll just like to focus on 3 points. You see, still we are, as Dr. Soumya was telling, we are still not following, or whether it is in the private sector, whether it is in the government sector. At the first go, again, you see the CBNAT was not done. Even after so much of talking about various issues about the program, CBNAT was not done. I think that is one lesson we should have done. It should have been done at the first go. And again, the second point, the same good old story. When the regimen is failing, we are adding just a single drug. Whether it is the private practitioner or whoever it is, still our teaching, our message is still not percolating to the people who are practicing. So that is again one aspect which the program and all of us, where we fail as the teachers, we are failing as we are not possibly teaching enough to the private practitioner. How come he will add still, after so many years, if he is a TB specialist, if he is handling a case of TB, he should know how to treat a case of TB. I mean, it is I should say that with the emphasis and with the some degree of sarcasm, he has no business to add one single drug to a failing regimen, so-called failing regimen. And the third point, which generated actually our friend from West Bengal, the microbiologist friend, he very rightly raised the point. Again, I had got the same point in my mind. What is the significance of gene export in a case who was already treated earlier? The same issues, same questions. Is it it is a dead gene, it is a dead DNA was detected. So what is the significance of that? And then you are detecting rifampicin resistance out of that. And then more interestingly, the culture did not grow the bacteria. I understand it is a vascular disease. I understand that part, but you see, then my question is, what is the significance of gene export that is as a low detection in a already treated case? I say it was all dead DNA which you are detecting. But question is, but I think again there are many questions under that situation when you are going to give somebody treating somebody with MDR long-term regimen. I mean for a longer duration of therapy, I think a discussion with a multidisciplinary team discussion is required under these circumstances, like the microbiologist, the clinician. So we have to take a call whether we should go ahead in treating the patient or not. Again, very rightly, Dr. Singla, as he told, the clinical decision at that particular, and that was taken, and I will go with the team. They must have decided. There was abscess, there was, the lymph nodes are growing. Maybe they took that decision. But my question is academic question. What is the significance of this detection of, this, I say it is a dead DNA, it is a dead bacilli was there, and you detected that. So why did you go into all these things? You subjected the patient for 18 months of treatment and all those complications. So, but I think a call, so all case, every case, each case in clinical medicine is a challenge, and we have to take up that challenge. But I must say the overall, the management, the approach, the complications, and then we should know what drugs will produce the electrolyte imbalances. All these things are required, and a multidisciplinary team. The subsequently things were taken up very in a detail. But I think while deciding to put up the patient on treatment, then some discussion, some deliberation was needed, and I'm sure the team must have done that. So these are only some of my few observations and comments, and thank you, Kanita and Dr. Singla, and the team as a whole, and very nice case you have shown, and it was really a challenging case, I should say, and we have learned also many lessons, and I'm only disappointed that why people are not following the guidelines, why I will still again saying that I was little disappointed why gene expert was not done at the first go. I mean the CB-NAT, whether it is a TrueNAT or gene expert, that is a different issue. And secondly, why the gentleman added just one single drug to a failing regimen. Thank you.
Thank you so much, sir. Thank you. And there are many questions in the chat regarding replacement of drugs and the drugs added later on. So I think we'll listen to Dr. Singla, and if still some questions are unanswered, I'll take those questions. So over to Dr. Singla.
Sir, just one clarification for the case to Bera sir's comment that the gene expert was done at the private sector only. Sir, it was done at the second, third consultation of the patient. It was done at private sector only, and then patient came to us. So it was their decision to, they did it at the first treatment. It was a first treatment of the patient. There is no past history, and patient going to private sector, and there the biopsy is done, and there only the gene expert is there done. And then after 1.5 months of treatment, patient is not improving. So here we have not done gene expert. It is a private sector report, which we have also shown in the case. So it was done at first go only, first consultation or second consultation only. Sir.
Mute. Yeah. So Dr. Singla, what are your comments?
Yes, you see, I must say it's a very, very interesting case, and many issues have been raised, and Dr. Behra sir has almost highlighted most of the issues, but a few things which I would like to discuss again. You see, number one, in our institute also, whenever we have a cervical lymph node, we take it as a chain. We should look for mediastinal lymph nodes. We should look for abdominal lymph nodes also. Sometimes we see cervical glands are persisting after treatment, but the mediastinal glands have cleared, abdominal glands are there, they have been cleared. So we should always see as a chain of all the three sides, and it should be routine wherever it is possible. And again, like in this case also, if there is any extrapulmonary TB anywhere in the body, may it be brain, may it be the bones, may it be uterus, wherever the intestine, we must get the X-ray test done. In this case, fortunately, it was done, that was normal, but what we have seen, and the literature also says, almost 25% of the EPTB cases are expected to have a normal chest X-ray. So what is the advantage is that we have another source of getting specimen. In case we find lungs are involved, then we can ask the patient to have a good amount of sputum or reduced sputum. So we have another source. We can't go on repeating the extrapulmonary TB site. Although lymph node is a comparatively easier site to be sampled, but still we would like to avoid it whenever it is possible. And as already been highlighted by you all, including Dr. Behra sir, that we should follow the universal DSP. If at the baseline FNAC could have been subjected to CB-NAT, we could have known the results, and patient could have been put on the appropriate treatment, which was not done just on the basis of histopathology or the cytology. Patient was started on treatment when we know the CB-NAT is widely available all across the country, and they can link up with the government college, with the government facility to get the CB-NAT done. And now you see after 1 month, the treating team observed lymph node has increased in size. So usually at 1 month, in case you're giving the appropriate treatment, it is more likely to be iris, immune reconstitution, inflammatory syndrome, rather than a drug failure. So in these cases, first we should think of iris. If at all you want to repeat, one can repeat the FNAC, and rather than adding a single drug, this was definitely avoidable. But now, since patient had taken 1 month of treatment and levofloxacin was added alone, and as later on we know this was a case of the rifampicin resistance, then very chances are there very much that levofloxacin could have been become resistant in this case. Levofloxacinolones are among those drugs, if you take them irregularly, in that case, even 1 week is enough to develop the drug resistance. Normally, with other ATD, we need 3-4 weeks, but with quinolones, even 1 or 2 weeks of taking them irregularly can cause drug resistance. So in this case, we are not even sure whether patient was having a resistance to fluoroquinolone or not, but we have to treat him as a possible case of fluoroquinolone resistance. Then after 1.5 months of this first-line drug, levofloxacin, now the FNAC was done, which showed MTB detected very low and rifampicin resistance. I will not like to repeat the discussion on this. It has already been discussed that how to handle the cases which are having MTB detected very low, but there is RIF resistance. There are microbiological aspects to this and there are clinical aspects to this. So we have to take both the things in mind before we take a call. And if worst of all, we are still not able to decide, better to repeat. Like in this case, lymph nodes, cervical lymph nodes, I always feel in such cases, rather than giving 2 years of longer treatment with MDR, for the MDR, the second line drugs, better to repeat and decide whether we are treating drug sensitive TB or drug resistance TB. And now, the how to rule out fluoroquinolone resistance. In these cases, you have rifampicin resistance, you have the history of taking levofloxacin for more than a month in a case who was not responding. So we should make all attempts to look for whether I'm dealing with a case of FQ resistance or not. Ideally, second line LPA, but in as per the current guidelines of the country, in cases of extrapulmonary TB, the second line LPA has not been approved. So, I mean, that question, although I always feel as a clinician that in case you are able to get it, why not to do it? But anyway, we have to respect the national guidelines. Second is we have expert MTB XDR available in the country. But unfortunately, in the national program, it has not been sort of approved by your NTEP. I think it's high time we should think in that line. You see, we are getting cases from the private sector where they are doing the expert and MTB XDR and they are documenting the resistance to fluoroquinolone in addition to the rifampicin. And even the clinical probability of FQ resistance is quite high in these cases. So I sincerely hope and request our national program to have a relook at this, whether we can introduce the expert MTB XDR as early as possible in the country. Of course, second option is the do the midget culture, which in this case was negative. Otherwise, in case midget culture is positive, then we can do all 13 drugs DST from a lab where it is available so that we can really take a call. Like in this case, the patient had to stop benzoate, the patient had to stop cycloserine. We are not sure about the fluoroquinolone resistance. So such cases, we have to be very clear in mind what to treat him. Next, please. So, like in this case, first of all, the regimen, whether shorter or longer, as already explained by the treating team, because patient had taken more than 1 month of levofloxacin, so they kept the option, which was very much correct as per the guideline, the longer oral regimen to be given. But since they see in this case the sensitivity to fluoroquinolone is doubtful and we have no answer to that, linezolid intolerance is there, cycloserine intolerance is there. So in this case, when we are replacing 3 drugs, one drug delamode has already been replaced. So I feel, although I agree with Dr. Parul that as far as possible we should avoid giving injection, but in this scenario, given a choice, I would like to add amikacin also. Question with the pyrazinamide is, if you see the guideline also and the evidence, pyrazinamide is likely to be effective when you have a documented sensitivity. And in our country, among MDR-TB cases, the possibility of Z resistance is 20% to 30% as per our national drug resistance surveillance report. So in these cases, between the two, and when 3 primary drugs, they are doubtful, all the group A drugs, better we give a stronger intensive phase. So with Duraminid as a first replacement, second replacement as injection amikacin we should consider, and if required, PZA may be added. So that's how I would like to treat this. And again, summing up the entire case, you see, treating MDR TB cases, drug resistance TB cases is always a challenge, especially when we do not have good microbiological reports of the patient, like in this case. So that becomes a challenge. We really have to go for the clinical background also, what we are treating. Managing adverse drug reaction is the key point in treating the MDR-TB case. That's what we have learned in the last 20 years when we are treating MDR-TB cases in this institute. It's easy to start the drugs, but difficult to sustain the treatment till the end of the treatment. And especially with linezolid, this peripheral neuropathy is very, very common. And I always say you catch them early. In case you are delayed in diagnosing them, patient already has progressed to grade 3 or grade 4, and then whatever you do, whether you stop it or you do reducing the dose, I have seen it doesn't work. So better to catch them early. The moment they have signs of this, start going for the investigation, nerve conduction studies. You may hold the linezolid and then give symptomatic treatment. In case patient is all right, we can consider giving 300 milligram to this patient. But in case you are delayed, then sometimes it is rather most of the time it is irreversible, and patient will remember the doctor in a bad taste. And I feel it is avoidable provided we know about it. So, and one more, the next slide, please. One more thing is about the QTC prolongation, like you. So there are three rather, but commonly used are QTC Bezet, that is Bezet correction. Then we have QTC Friedreichia correction. In our program and in managing the drug resistance TB cases about the cardiotoxic drugs, we need the QTC Friedreichia levels. So when we started treating them in way back in 2017, we found many patients had very high QTC levels, but they were otherwise normal, no complaints. ECG was also no arrhythmias, nothing. So we were wondering what is happening. So then we realized that most of the ECGs in our country, maybe more than 95% of the ECG machines in the country, whether Indian make or Chinese make, whatever it is, they are giving values as QTC Bezet. And the QTC Bezet is much, much higher than QTC Friedreichia, and higher the pulse rate, more the chances of the difference. Like in this table, you can see this is a table which we shared with the Central TB Division, that this is what is happening. You can see the sixth case, there is a difference of 45. So patient actually had QTCF of 450 milliseconds, which is very well within normal limits, but the ECG machine showed 495. And the treating physician tends to stop the drugs and do this thing and that thing. So fortunately, the Central TB Division took the cognizance of this, and then they released the guideline that we must calculate or ensure that what is the QTC Friedreichia of the patient. So please request all of the people who are attending that we should be aware of this, and before taking a clinical call of stopping or doing any other action, please ensure that we are acting on the report of the QTC Friedreichia, not QTC Bezet. So again, I must thank the team from Ahmedabad, Dr. Parul and all, that they have presented a very, very interesting case, and it gives so much of messages to us in a single case. Thank you so much.
Thank you, Dr. Singla. I hope it has answered most of the questions. You still have any questions? Actually, we are crossing our time, so maybe I will not take the questions. So, in very short, I'll just like to say the take-home messages. The take-home messages would be first and foremost for our periphery. We must train our health workers regarding recognizing the symptoms of ADR, referring the patients higher up. So first and foremost thing is training of our health workers. They should refer the case as quickly as possible. They should recognize what is peripheral neuropathy, what is anemia. They should know these terms, and they should get hemograms done on a regular basis as given in the guidelines. Then these patients should be referred to the district TB officers, and our district TB officers should be well trained to manage the DRTB. We are holding regular trainings for the DTOs on PMDT. So we have to ensure that all our DTOs are trained so that they can at least manage the basic MDRs at the district level. And whenever there are multiple ADRs like we have in this case, these cases should immediately be sent to nodal DRTB center, where there are multidisciplinary people sitting together. There is a nodal DRTB committee which will look into such cases and help these patients. So there are very clear-cut guidelines there, and we should try to follow these guidelines. And follow-up, of course, should be done at the DTC. Once these patients are back from nodal DRTB center, the district TB officer should follow these cases on a regular basis, should meet all the DRTB cases at least once a month and find out what is happening with them. So with that, I would like to wind up today's clinic, and now I request Dr. Ashok Bharadwaj, sir, chairperson for NTF, to give his vote of thanks. Dr. Bharadwaj, sir, is there? Dr. Ashok Bharadwaj?
Yeah, join.
I think we are not able to connect to Dr. Bharadwaj, sir. So in that case, I would request Dr. Singla to give his vote of thanks.
First of all, I would like to thank Dr. Soumya. You see, very inspirational words she said, and she also said the priorities of the country. And she also guided us that through these clinics, what should be our priority to be discussed. And we can assure, ma'am, that we are with you in this struggle for TB elimination in the country. And this is a good forum where we have 500, 600 hubs and almost, say, today, like around 2,000 people joining. And we are seeing many medical colleges, they take it as a academic activity, just like seminar journal club, that their students, they come in a room and they are joining, including our own institute also. So once we know these priorities and you're there as the principal advisor to the government, we will definitely work in that direction. And I also thank Dr. Behra sir as a national expert and the entire team from Gujarat who presented the case, discussed the case, and also all the senior faculty, all the STOs, DTOs, the STDC directors, the medical officers, and all those who have joined, the medical students have also joined, that they really, by their participation, they enriched the discussion. Thank you all. Thank you very much.
Thank you. And we thank the ECO team who has been supporting these activities throughout. We propose our thanks to them also.
So we thank you, sir, Rupat Singla, sir, and all the team, entire team, sir, for giving us opportunity to discuss this case. Thank you from Surat and Gujarat.
Yeah, please do give your feedback. We have given a feedback form on your mails, and we would like to have your feedback so that we can improve our next clinics. So thank you. Thanks a lot. Thank you so much. Box. Okay. The link is in the chat box for the feedback. Please keep filling your feedback formats. We are keeping the session on till you fill the feedback forms.